So if you just break it down, and you said you take heart surgery patients, they either have complete blood evacuation postoperatively or incomplete. Of the patients who have incomplete blood evacuation, some of them will go on to recover, but others will have impaired recovery due to that retained blood complex. And that retained blood recovery, or that impaired recovery, can either be acute, subacute, or chronic. Acute being sort of the tamponades and hemothorax. For example, when you take a patient back for bleeding, you open them up, almost a majority of the time you're going to have blood around the mediastinum, blood in the chest tubes. Subacute meaning these effusions, or chronic, whether or not this can cause some fibrotic changes later in the recovery. So we set out to try to determine exactly how often do people end up in these categories. So one of the first places we went to look was in the United States using some of our national databases where we code these patients pre and post-operatively. And we found that we could find evidence of retained blood complex in about 17% of patients. A lot of it were effusions. And then through these databases, we were able to get a hint of just what impact this has on cost, at least in the United States, and I know it's very different here. But in the United States, it increased cost by about $28,000 per patient, which if you take a program that does 1,000 cases, that's almost a $4 million, $4.5 million problem that they don't get reimbursed for. So we thought, hey, this is a significant opportunity for hospitals who are looking to improve the economics of their hospital, improve the management of their complications so they can have a more financially solid foundation to work from. This is a good opportunity to look at.